Thank you so much for the invitation. It's a pleasure to be here. Let me reflect with you what are the 10 most important achievements in ophthalmology, and the OCT is definitely on the list. So introduced in the 90s, developed in Boston. I think it was Heidelberg that paved the way into the market and into the clinics. It really changed the way how we work these days. Now let's reflect a little bit about the retinal ganglion cell. It is a very special neuron, and if I reflect what is so special about it, well, first, it codes spatial information. One retinal ganglion cell codes the information of 100 photoreceptors. It is a very long neuron, 10 centimeters. Most of its volume is outside the eye. And what is very important inside the eye, it is not myelinated. And for that reason, it's actually very simple, it is highly energy dependent. So it's probably the most sensitive neuron in our body that we have. If you have states of mitochondrial malfunction, hypoxia, etc., and it's subjected to lifelong stress, which I would like to indicate here. We have a pressure gradient, it's narrow, and as an eye movement person, this poor axon is constantly deflected by probably 90 degrees whenever we move our eyes. We all know that macular diseases are the #1 cause of legal blindness, data here from Germany. And for four cases which are legally blind, one is due to optic atrophy. And in this group, 1 out of 3 is related to optic nerve diseases other than glaucoma. And I want to cover these diseases briefly with you now. I will focus on AION, on optic neuritis, on papilledema and hereditary optic neuropathies. And of course, as Alexander has told us already this morning, this all converges to optic atrophy. So disease #1, the second most common optic nerve disease, AION, usually elderly men. They wake up in the morning with a field defect. Risk factors are well known: small cup disc ratio, sleep apnea, diabetes, nocturnal hypotension. And what is really important, because not many colleagues are aware of that, it is not a thrombogenic disease like stroke or like myocardial infarction or like a central retinal artery occlusion. It is a focal compartment syndrome in the optic nerve head caused by hypoxia that leads to swelling and then more hypoxia. So it's like a vicious circle. If we look at a molecular level, the retinal ganglion cells usually die irreversibly within 1 day. And that is the reason why I personally think that any clinical trial on AION does not make sense. And right now, 2 well-known companies, Dompé, Italy, and Oculus in Switzerland, are setting up clinical trials to treat AION, which I think is not possible if you don't do that immediately. And we can never do that. And I would like to quote a very nice sentence by the already deceased Professor Harry from Iowa: "A disease which has no treatment has many treatments advocated. It becomes a graveyard of promising and then discarded therapies, some of them even harmful." I think that is a very important sentence. So how can OCT help in that disease? We don't need to do that. We can see this swelling and atrophy with fundoscopy. But of course, these days, we rather use the OCT than taking the ophthalmoscope, at least our young residents. And that is the time course of atrophy of an individual patient from our clinic. And what you can see here is the swelling subsides within 2 months, and the ganglion cell layer, the affected part of it, is lost after 1 month. So nice. But is it useful? Here I show you why it is useful, actually. In half of the cases, and that is a relatively new finding, you see intra or subretinal fluid in AION, in non-arteritic AION, which is the most common form. So when we saw that first, we were a little confused, but we all must be aware of that. And if you have giant cell arteritis, and the dangerous cause of AION, you may look for PAM, which is paracentral acute middle maculopathy, which is a very important OCT sign. And you see that in 1 out of 3 patients with giant cell arteritis. And Steffen Hamann, who is sitting here, did a nice study on 40 eyes, mixed arteritic and non-arteritic AION, and showed that these signs are very specific for the discrimination of this important differential diagnosis that we shall never miss and do wrong. Now I would like to switch to the third most common optic neuropathy, which is optic neuritis. It is young patients, usually female, and vision goes down within days, and then it recovers nicely, usually. We all know that it is related to multiple sclerosis. What you may want to know is that 3 years ago, that disease got a, I think, rather complicated new classification published in the Lancet Neurology. And but what the essence basically is, in our area here, about 90 or maybe even a little more % of the cases are either isolated or multiple sclerosis related optic neuritis, and the other are antibody mediated, MOGAD and NMOSD. I don't want to go into the details here. The time course of the symptoms and the atrophy have been displayed by many groups. Visual acuity, as you can see here on the left, usually recovers nicely within a month. And then we see RNLF atrophy within, let's say, 4 months, and GCL atrophy, which is a little faster. Now, something very important to memorize. Last year, the multiple sclerosis criteria got revised for the, I think, 6th time. The first ones are 60 years old, then it was Poser who made the next set of criteria, and then the McDonald criteria that underwent its 5th revision last year. And why is it important for our group today? They included the optic nerve as the 5th distinct anatomical location, which can be, which can show changes, which indicates multiple sclerosis. So that means dissemination in time as an MS criterion is not necessary anymore. And now you can come to the diagnosis of multiple sclerosis on a technical basis, even without clinical symptoms. And what does it mean for the optic nerve? Either we use the MRI, and if you have optic neuritis, there is a sensitivity of the MRI with contrast of 80%. 80% of the patients will show some, signal and contrast enhancement behind in the retrobulbar part of the nerve. We can use the VEP, and of course, we may and shall use the OCT. And here the IED is the buzzword of this year, the inter-eye difference, which we heard earlier this morning, especially with regard to normal tension glaucoma. If there is a difference of 6 micron in the RNFL or 4 in the GCL plus IPL, that counts as an MS criterion. So how do we calculate it? Either we subtract the RNFL reading. For the macula, it's a little bit more complicated because the Heidelberg machine yields volumes, and then you need to reverse it into thicknesses. So maybe Heidelberg can incorporate that in the future. And it has been applied by, for instance, Gabriel Psteh von Vienna, when he looked at his MS patients and looked for the probability of a second MS event. The inclusion of the optic nerve based on OCT dramatically enhanced the accuracy of the prediction of multiple sclerosis. So for our neurology colleagues, it is a very important tool now. And as it has been mentioned before, the quality of the OCT imaging is very, very important. So you cannot do a clinical trial without complying to the OSCAR IB criteria, which have been defined not by ophthalmologists, but by neurologists. And it has been shown that the correlation or the variability, if you apply or confine to these criteria, is much, much higher than if you do not. So that is really something we have to keep in mind when we image the optic nerve, especially in clinical trials. We also used the OCT in our German optic neuritis trial, and I'm super grateful to Heidelberg Engineering. So that was 10 years ago that we could use the new presets that you created for the first time in Germany, the BMO, the posterior pole, and all these analyses, and that helped us dramatically to create a lot of nice papers You all know it was a negative trial. We checked for the neuroprotection potential of EPO, but also we yielded data that will help to design better trials in the future. For instance, if you do a power calculation for sample size determination of a future trial, you can do a neuroprotection trial if morphology is the primary outcome with 70 patients. The GCL is much, much better than the retinal nerve fiber layer. In multiple sclerosis patients, you also see changes in the more outer layers of the retina, something that is called microcystic macular edema. Actually, it is not an edema, it is just a cavernous changes in the inner nuclear layer, like a hole due to neurodegeneration. And that is very often in bad states of multiple sclerosis. However, that sign is not specific for optic neuritis or multiple sclerosis. You see that in glaucoma, in AON, and in any other degenerative disease as well. You can also use the changes of the inner nuclear layer to predict the course of multiple sclerosis. Now we switch to the next disease, which is, in comparison to optic neuritis, much more rare. 50 new patients in Germany each year. Leber's hereditary optic neuritis, which at least in the beginning has a very similar clinical characteristic as optic neuritis, and therefore it gets easily mixed. And that is maybe one of the most important sentences of my presentation. Usually male patients, however, young patients, and they usually don't have recovery. Yeah, I don't want to enter deeper into this disease. Is OCT useful here? Of course it is, because in the early phase, we see RNFL swelling and then it undergoes atrophy. And the temporal sector, which is shown by the violet line here, is the first one to swell and undergo apoptosis, and all the other sectors follow later. Disease number 4, and the last one that I want to touch upon, is papilledema. Usually you would use the BMO scan or a circular scan to see or to look for changes in the RNFL. But that might be a pitfall, because if you have long-standing papilledema, of course, the axons disappear and the swelling resides. So that does not mean that the disease is getting better. It can mean that the disease remained untreated. So what do we do instead? We just created ourselves a little preset, and maybe Heidelberg can also do that, you know, as a standard protocol. We have a cubic scan, 15 by 15 degrees, so it's 37 scans. And then we manually correct these scans to have 2 outlines for volume calculation, which is the inner limiting membrane and Bruch's membrane. And of course, in the optic nerve thread, there is no Bruch's membrane, so you have to interpose it manually. But it's easily done. It takes a couple of minutes per eye. And if we could get that automated, that would be wonderful. Maybe we can discuss that together. We did a trial in patients with AIIH, so pseudotumor cerebri, compared to normals. And this way of analyzing the optic nerve thread was much more specific and sensitive than just looking at the RNFL, as you can see here in this ROC analysis on the right side. And so in a normal eye and in a swollen disc, it takes between 2 to 4 minutes to do that. So nobody likes to do that, but it's useful. Yeah, it takes some time. And we defined a cutoff value between normals and papilledema, which is 3.8 cubic millimeters. That is highly sensitive and specific. I'm not going to touch upon the differential diagnosis to papilledema, which is Drusen. Steffen Hamann is the expert. I'm really looking forward to his presentation. Now, during the last minutes, I want to go a little bit more inside the head and look at the skull base and the chiasm. What I'm showing you here is an MRI of a patient who had a craniopharyngioma. As you can see, it compresses the chiasm and the left optic tract, okay? And he has minor visual defects. The right eye is perfectly normal. The left eye shows a mild defect that is vertically delineated. And when you look at the RNFL, you would say it is normal, I mean, it is normal. But if you look at the GCL, you see a bilateral, incongruent, homonymous GCL defect. And I find that very interesting because I have many patients with optic nerve or visual pathway compression, where I think that the GCL is more sensitive than perimetry. And it makes me think how we should manage these patients in the future. Now we leave the retinal ganglion cell and we go beyond the lateral geniculus body, so to the fourth neuron of the visual pathway, retrogeniculate lesions. Please take a look at this set of fields, a homonymous defect which is incongruent, and those were the optic nerves, and the patient was sent with a question, is it normal tension glaucoma, because the pressure was normal. And I think you all would agree that it's not glaucoma. And what you can see, he had a right-sided occipital lesion because he had a postpartal intracranial hemorrhage, and for that reason, damage to the occipital pole. And here again, when we look at the RNFL, in the contralateral eye, we see the horizontal, what we call band atrophy, in the nasal and temporal sector. And in the ipsilateral eye, we see temporal diminishment of the RNFL. But most impressive, again, is the ganglion cell complex, where you can see his quadrantà, let me call it quadrantanopsia in the GCL, super sensitive. Another example, a brain tumor in the parietal occipital part of the brain, bad visual field defect, and very typical changes in the RNFL. And you even can see that in stroke patients. Within 3 to 6 months after stroke, due to transsynaptic degeneration, you see changes in the GCL. I would like to summarize what are my take-home messages. OCT is an extremely powerful tool in clinic and in research and development. And sometimes I think in the daily routine, are we slowly becoming radiologists looking at, computer screens instead of taking the ophthalmoscope? I think especially now it is super important that neurologists and ophthalmologists talk to each other, especially when they deal with multiple sclerosis. The likelihood that you have an inter-eye difference that I just mentioned before without having any disease, or maybe having normal tension glaucoma, might lead to the fact that many people, many patients receive wrong diagnoses of multiple sclerosis and maybe get overtreated with very expensive drugs. So please always judge the nerve fiber layer in conjunction with the ganglion cell complex, especially in case of disc swelling. And I tried to raise your sensitivity to calm down the neurologists. More and more of them are buying OCT machines, and they even speak to the Gemeinsame Bundesausschuss now to get OCT reimbursed. How painful is that? It might be really a wrong development. What are the confounders that lead to misinterpretation? For the RNFL, it is refraction, as we have heard before, and it is axonal swelling. And if you look at the GCL, of course, you have to be sure that the patient does not have retinal disease. And I would like to leave you with my last statement, which is a question: does the GCL maybe have a better sensitivity and specificity than perimetry? Thank you very much.